help growing your family? The BioART Fertility Center in Johannesburg is waiting to help you fulfill your dream. Our highly professional staff offer you world-class care and cost so low that you can afford to dream. State-of-the-art equipment and remarkable success rates. We have been treating all aspects of infertility for more than 26 years. Contact us now to make your family a reality. BioART Fertility, where life begins.
Thank you, ladies and gentlemen, and we appreciate that you are still here with us. Next on the podium is Dr. Mohamed Cassim. Dr. Cassim obtained his undergraduate degree from Wits University in 1984 and his fellowship from the College of Medicine of South Africa in 1991. Dr. Cassim set up his own fertility unit in 1993, the first person of color to do so in South Africa. During 1996 and 1997, realizing the need for advanced training in the field of fertility, he trained with the fertility unit at Herlev University in Copenhagen, Denmark. And Dr. Cassim recently co-authored a paper with Dr. Tasneem Mohamed, which received the International Young Scientist Research Award, COGI, in Vienna, Austria. He is currently director of the BioART Fertility Clinic in Saxonwold, Johannesburg. Dr. Cassim is talking about causes of IVF failure and how to minimize the risk. Welcome, Dr. Cassim.
Good afternoon, ladies and gentlemen. I'd like to start by acknowledging and thanking the organizing committee for giving me this opportunity to address you on a subject which I believe is extremely relevant and important. As mentioned, I've been in the fertility space for nearly 30 years now, and in this time I have witnessed a number of successes, but sadly I've witnessed even more, if I may say so, failures. And unfortunately, failures are things that doctors don't really want to talk about. And on the other hand, IVF patients demand answers, and rightfully so. Just to clear the air quickly, IVF, for all intents and purposes, in vitro fertilization is the production of embryos through the means of laboratory intervention, fertilizing sperm and egg, producing embryos, and then transferring these embryos into an environment, in this case the uterus, which is prepared for implantation. So that basically, in a nutshell, summarizes what in vitro fertilization is, so that there's no confusion here. I will start my talk. In fact, I prepared the talk in a different manner. I was going to talk about the consequences of IVF failures, but I'll leave that for the end. And rather, I'll get straight into what the important aspects I believe are responsible for IVF failures. To do so, one has to ask the question, what are the drivers for success in IVF? What makes IVF successful? And the first and very important one, and as the previous speaker had just gone through in some detail, is the number and quality of eggs. Now, we were told and we know that women are born with a certain amount of eggs. That's your gift, your egg basket from birth. And as you get older, this basket gets progressively empty, and you are then close to menopause, you are then depleted. So not only does the numbers decline, but the quality also declines. The good eggs come out first, and the poorer eggs that's sort of sitting at the back of the class get recruited towards the end. Importantly, sperm quality. So we need to ask, because it takes two to tango, so obviously sperm quality is important, and I'm going to elaborate on this in a short while. The number of good quality embryos. Now the emphasis here is actually on good quality embryos. It's not about just number of embryos, it's about quality of embryos, and I'm going to go into that a little bit more detail. And then lastly, implantation factors. So factors which are important in the actual seeding process. So to start off with, irrespective of age, not all eggs are equal. So we know that age affects quality and quantity of eggs going down the age groups. But not all eggs are equal. So even within the same patient, at the same time in a stimulation cycle, you will get different quality of eggs coming out of that patient. A large proportion of those eggs are artificially and iatrogenically created, and I'll talk about why. Now look at this. I don't know how well it's projecting on your side, but this is just an example of the type of eggs that we can expect from a patient. So right on top on the left is a normal egg, so-called normal egg. And then you'll see various differences within the egg and within the shapes of the eggs and so forth. And this is just to highlight the fact that when women or when patients talk about eggs as a collective, it's not from our point of view, from a fertility perspective, it's just not about eggs. It's about what quality of eggs are we dealing with. So what are the factors that affect quality and quantity of eggs? And firstly, we talked about maternal age and the so-called natural decline. So getting older, your egg quality and quantity decreases. But the second point there is, what about eggs? Are women of a certain age, are all women of a certain age the same? The answer is no. And what makes certain women have less quantity and quality of eggs for their age? That means lower than expected reserves. And then the third factor is what we create as fertility specialists. So we subject our patients to what is called ovarian hyperstimulation. We give them injections, we give them medication, we give them hormones, and we say, make eggs for us. And in the process, what we're actually doing is we're recruiting the good, the bad, and the ugly. So we're getting a lot of eggs coming out, but we are artificially creating the problem. And to a large extent, this is where the medical profession, I think the fertility profession, needs to take some responsibility for what happens. And then the next point would be inappropriate stimulation. So sometimes you shoot below the target. So you haven't assessed the situation in its entirety. And you stimulate the patient, but you understimulate the patient. Then you get less eggs than you're supposed to get. And you start asking questions. Well, you didn't respond very well. You're a poor responder. No, you're not a poor responder. You're a poor responder because you were given the wrong stimulation. You were given the wrong starting dosage. That's why you didn't respond. So that again, the onus falls and the responsibility falls on the doctor, on the fertility clinic. So sometimes you are not to blame. It's just that we have just not aimed at the right targets. And then the last point which I'm going to go through is the laboratory aspects. Not all laboratories perform the same. So if people have this idea that you walk into a showroom and you buy a car and you drive out, this is the same thing. I'm going to do fertility, I'm going to get a treatment, I'm going to have a baby, and off I go. And that's the wrong thing, because different clinics have different levels of expertise in the laboratory. You can have the same equipment, exactly the same duplicated lab, but if your lab technicians and embryologists are not experienced enough. When I worked in Denmark, the first thing they told me is that your lab technician can only call herself or himself proficient at ICSIs if they've done 1,800 ICSI cycles. And I said, what? At that time in South Africa, we were probably doing, as a country, we're doing under 1,000 cycles as a country. And this clinic says to me, you're going to do 1,800 ICSI cycles before you can tick off your embryologist as being proficient. So I said, wow, that's a tall ask. But that's exactly the point, that you get embryologists that are just new on the block and are not able to handle egg, sperm, and embryos the way they should. And unfortunately, you as a patient pays the price for that. So these are some of the things that I've over the years sort of established, and I think it's important that you as a public, as a consumer, understands where the pitfalls lies in this whole IVF scene. Now, coming back to maternal age and natural decline, okay? This graph, and you saw the one previously as well, quite easily puts that into perspective. So as a woman gets older, her reserves naturally drops, but at the same time, her chances of a miscarriage starts going up. And that's because of the quality of the eggs towards the end. So they have genetic abnormalities, they have mitochondrial problems, energy source problems, and therefore they can't perform the way they should. So just like me getting older now, I can't run 100 meters as fast as somebody else can, I suppose, but that's exactly the point. You run out of energy and you can't do what you're supposed to do. So this is an important thing, and I will be bringing this back when I talk about management and treatment. So age of the woman, chances of miscarriage, and the increase in genetic problems as you get older. But now, this aspect that we touched on earlier is when you have lower than expected reserves. So a woman comes in and says, doctor, you told me my reserves are low because you did an AMH test or an enteral follicle count test, and now my eggs are lower than, the reserves are low. What can we do about that? We'll talk about that shortly, but this is just to show you what happens in egg reserves, AMH levels in particular, with age. So when these are all percentile graphs. The solid line there is the one that's, the solid line one is the average, but a woman can be anywhere on that particular graph. So what are the causes of lower than normal reserves? What causes this problem where you suddenly have less eggs than you should be, and you may be heading towards menopause when you're 25 years old? So one of the things obviously is inherited. So I mentioned that you inherit this egg basket, and sometimes in the so-called embryology and embryological development, when you as a female are in utero, things may not be as good, maybe not as normal, either genetically or non-genetically, and you inherit less eggs than you should be, so you're shortchanged. The next important thing, very important aspect, is lifestyle. Okay, so there's a lot of evidence to show that external factors, and I'm going to stress external factors in the form of hidden or invisible radiation. I'm opening myself up here, but there is a substantial body of evidence coming through that in fact our exposure to this type of radiation, and particularly in the males, cell phone usage, frequent cell phone usage, close to the gonads, close to the testicles, close to the ovaries, may in fact cause some form of damage to the development and the quality of eggs and sperm. So there's a lot of stuff out there that we're not aware of, we cannot see, but may well be responsible for some of the damage. It goes without saying, I mean, diet, stress, these are factors, smoking, all these are additional factors. But I just highlighted certain factors that you cannot control. Diseases, there are a number of diseases that can cause the ovaries to become damaged, including autoimmune disease, some form of benign or malignant disease of the ovary, HIV and STIs. Now, we did a study, and that's one of the papers we got the award for in Austria, was the study that showed that patients with HIV, with or without antiretroviral therapy, are more likely to suffer diminished ovarian reserves for their age. So we can see that from some form of external influence, like viral infections, can damage the ovaries and the reserves without giving you all the symptoms. And then, of course, endometriosis, which is the enemy number one. Then medically inflicted or iatrogenic surgery for ovarian cysts. A lot of patients end up in theater having ovarian cysts removed, and in the process, some of the normal healthy tissues also removed, and then they shortchanged. Now, there's thousands of eggs per millimeter or cubic millimeter in the ovary, and just taking out ovaries or removing tissues in the process of doing an operation can significantly drop egg reserves. Then, of course, there are things like ovarian drilling, which a lot of patients with polycystic ovaries still are recommended, and that can be sometimes traumatic to the ovary. Likewise, radiotherapy and chemotherapy. So those are external factors. Now, we talked about earlier that we as doctors sometimes create the problem, and this is one of the issues. We put the patient onto stimulation drugs. We say, let's go for it. Let's get as many eggs as possible. And what are we doing? So I said we get the good, the bad, and the ugly coming through. Good eggs, medium-class eggs, bad eggs, all in the fray. And I don't want to labor you with the points, but egg recruitment is a process that takes at least 3 to 4 months prior to ovulation. So we think that a woman has a 28-day cycle. It's just 1 month that she's going to use up some eggs. No. So the recruitment process is actually a long process. So you start almost like an interview system. You advertise the post, you get a whole lot of applicants, you shortlist, and eventually you choose one. So this is exactly what happens over a period of 4 months. And what we're doing in our stimulation protocols is that we are pushing a whole group of eggs through, okay, that you may not have selected as your first choice. And there's a lot of studies, in fact the literature is full of it, where close to 60% of eggs which are produced through this process of egg stimulation, ovarian controlled hyperstimulation, will have genetic problems or aneuploidies. 60%. So what are we doing? We're saying, okay, woman, you've got 10 eggs, great. We're not telling you that 6 out of those 10 eggs might have genetic problems in them. So now you really don't know, okay, that you're sitting with 4 eggs that might only be of good use to you. So that's the important ratios that one needs to appreciate, that there are a number of iatrogenic, medically induced problems that we are creating. And the reason why this is happening is because we as doctors still don't have the ability to fine-tune the system. So we are just taking all and sundry and sifting out and eventually saying, okay, this is what we got left. So I think we still got a long way to go to perfect the art of in vitro fertilization. So, of course, there's laboratory problems, and you've got to expect attrition rates in the system. So you have 10 follicles, you might have 9 eggs or 8 eggs, and then it goes to the lab, and the laboratory has issues, and you'll end up with 4 embryos or 3 embryos, and then you'll have 1 embryo that's really normal. So this is because of the attrition rate that we actually push the numbers. But we are learning now that that's not really the right thing to do. So you can test your eggs. You can do what is called a polar body biopsy of the egg to see if the eggs are abnormal before you fertilize them. But firstly, it's very costly. And secondly, once you put the sperm in, you still need to know whether the embryo is normal or not. So yes, you can say, okay, now I've sifted out the sort of 60% bad guys, but then you put the sperm in, and the sperm might have some problem itself, and now you'll end up with an embryo that's also a little bit wonky. So you don't always answer that question by sampling an egg. Okay, so the question of cost again comes into it. Then inappropriate stimulation, I mentioned it earlier, I won't dwell on it. I said doctors sometimes shoot below the target. And I also mentioned laboratory conditions that may lead to egg attrition or egg damage or poor fertilization. The second aspect that's an important driver is, of course, sperm quality. Okay? And I'm just going to show you a little video of what we see under the microscope when a sample is put in front of us. So you see a lot of guys running around, and okay, that looks good. But when you look at it a little carefully, you say, hey, hang on, a lot of the guys are going in circles. You saw that? A lot of guys are actually spinning around, and they don't know where they're going. So that is some of the things that we need to actually address. That, listen, not all sperm are the same either. So this is just to show you the variations in sperm that you can get. So the sperm is divided into a head, it's got a midpiece, it's got a tail. But in the head itself, there's a huge number of abnormalities. And we need to determine which abnormalities are conducive to fertilization and which abnormalities are not. And we go back. In fact, this is a proudly South African invention. In the 1980s, late 80s, the strict Tygerberg criteria was introduced to the world. And to a large extent, till today, we still use Steigerberg criteria for morphology, for sperm head analysis. However, as time went on, and in recent times, we understand that morphology is not the only or the major player now. So there's a new guy on the block, and he's called DNA fragmentation, okay? Because we know that some patients even with normal morphology may have abnormal DNA in their sperm. So, okay, by and large, abnormal morphology equals abnormal sperm and abnormal DNA, but then there's still a reason why some patients are in this transition phase. Some men have got sperm that look so-called normal, okay, and may actually have DNA changes. We just did a study recently that showed that the inter-observer variation in sperm analysis, that means if you take a group of andrologists, laboratory technicians that look at sperm, they only agree with each other on sperm morphology and sperm parameters in 50% of cases. That means 1 out of 2. Okay? So we're not that brilliant when it comes to, and that's why we are at the moment doing a very interesting project on AI, artificial intelligence, to help us to actually narrow down that 50% and make it more standardized. Because we did the study with 4 different centers in the country, and they all reported on the same sperm slide, and we came up with a whole lot of different answers. So this is important to understand, that even in the morphology space, there may not be agreement between all doctors and all clinics. Now, DNA fragmentation, this is the aspect I was talking about. This is a new guy on the block. Okay? It's telling us that the sperm undergo fragmentation or changes prior to the morphology actually changing. That means before the shape changes, the guy is mentally ill already. So the sperm is already a little bit crazy in his head, but his shape is still good. Okay? He hasn't really manifested this. Okay? So that's exactly the issue here. Now, the problem is, when you're doing IVF, you're choosing a sperm to fertilize an egg. Can you choose a DNA normal sperm without damaging it? Because in this particular slide you're seeing here, these slides, the sperm have been labeled, have been tagged, they've been stained, okay? And you don't want to put a sperm that's been labeled and tagged and stained into an egg, because you don't know what that might do, because you're putting a foreign substance into the egg. So the question that you're asking is, how do we identify the so-called normal guy, normal DNA guy, from the abnormal DNA guy and still be able to use him? And this is the subject of a numerous number of studies, and we in our center are just completing an artificial intelligence program which will allow us to determine and establish that particular point. So I think the future actually lies in artificial intelligence and IVF. So going back to number of good quality embryos, I think it goes without saying now that sperm and egg make embryo. Good sperm, good egg, good embryo. And this is just to highlight what embryo qualities can look like. So these are day 3 embryos, and you can see there are quite significant differences. But what I'd like to stress is, if you look at the bottom 3, and particularly the last one on the right, you'll see a lot of what is called fragmentation. Breaks in the embryo, little bits and pieces lying around. Now, I'm going to come back to that point shortly, because the previous speaker sort of put a little damper on things and said, you really can't do much. And the answer is no, you can. You will be able to in the future do a lot. And I'll talk about that. These are blastocyst stage embryos. They are day 5 embryos. And again, quality varies according to the cellular structures and what the embryologist sees under the microscope. Now I'm going to come to this aspect of implantation. So here you've got the embryos, and you're about to now seed this into the soil. And implantation is a huge problem. Okay, this is just a graphic to show you how we transfer the embryos back into the uterine cavity. And the endometrium is that part which is attached to the inner lining of the womb. So that's the so-called endometrium. And that's the part that we will be looking at. So here's the embryo coming through the tube into the endometrium, and it's now going to have to find a lovely spot to implant. And then it has to go through these wonderful phases where it sort of starts to hatch out of its shell, remember, the embryo is in a shell. It's in a shell called the zona pellucida, and then it's got to break out of the shell. It's got to now oppose itself to the lining. It's got to then root itself into the endometrium, and finally it's got to embed itself. So these are the stages that poor embryo has to go through. Now, like all seeds planted in a soil, you've got to plant the seed at the right time. So it's the season versus the seed or the type of fruit. So this is called the window of opportunity. This embryo needs to find the situation or the environment in the lining, in the uterus, to be conducive, okay? And the window of opportunity can be as narrow as 6 hours. As narrow as 6 hours, okay? According to older criteria, which was based on really preliminary studies, we talked about a window of opportunity of 48 hours. Gradually, this has come down to 24 hours, and now, in fact, we're talking within 6 hours. So if the embryo and the lining are out of phase by 6 or more hours, it could mean that it won't implant. Now, I don't think the 6 hours is really strictly true, but anyway, let's say even if it's 24 hours, it's still very important that you need to put the seed in the soil in the right season. And then what about the soil? Endometrial receptivity. The soil must be adequately prepared. So it's got to be tilled, it's got to be plowed, and the problem is that it's exactly the same analogy. So the endometrium may be thinner than it should be. It may not be adequately primed. It may be too thick in some cases, and that will again cause implantation failure. Damage to the endometrium. Lots of patients have had infections, they've had polyps, they've had fibroids, they've had endometriosis. So there are a number of medical conditions whereby the endometrium is functionally impaired. Okay, and then there are blood-borne factors. So there's obviously nutrients that you need that are carried by the blood, and certain proteins and certain immune proteins that are important. Because remember, your embryo is 50% your partner, and that 50% is foreign to the body. It's like a foreign protein. And normally if you take a graft from somebody and put it into you, it gets rejected unless it's compatible. So there's certain things about the uterus that allows implantation to take place. It sort of turns a blind eye to a foreign protein. But sometimes the immune factors may be a little bit too strong and may cause rejection. Now, what's on the positive side? So all these are issues that can cause IVF failures, okay? But what are the ways in which we can mitigate these factors? Now, in terms of improving egg quantity or reserves, there are a lot of new technologies on coming out, okay? We, for example, have completed the first study on ovarian stem cells as a means of rejuvenating the ovary. Articles at the moment submitted for publication. But it's the first study of its kind where we've actually looked at a randomized control group. And what we've shown in some patients, particularly premature ovarian failure patients, that they've started to produce they started to menstruate again spontaneously. These are patients that were in menopause. And funny enough, some of them have fallen pregnant naturally. So there are ways, perhaps in the future, that we're going to be able to revive this ovary using PRP, platelet-rich plasma. So some studies have shown, in fact, there's one publication where PRP actually has worked, and we have experienced the same. So there might be ways in which you can inject the ovaries with rejuvenating products that might actually restore its functionality some way or the other and create either new eggs or reactivate and improve the quality of existing eggs. Growth hormone, I see that the previous speaker looked at growth hormone on the meta-analysis. There are numerous studies, okay, where growth hormone as an adjunct. Remember, we're not talking about one product on its own doing the job. So in many cases, where publications have shown it makes a difference. It does make an improvement. It may still touch the line, yes, which doesn't mean you reject the hypothesis completely, but it has favorable outcomes. So there are things like dual stimulation, where you can do 2 stimulations in one cycle. It's also shown to increase the number of eggs. Egg banking, soft stimulation. Remember what I said earlier? The good, the bad, the ugly. We stimulate all and sundry. So what about going back to natural? What about going back to natural and let nature choose for you? Okay, so this is what happens when you do natural cycles. Nature chooses the best egg that it's got, gives it to you, and you bank it. And you go again next month, and you do the same, and you bank it. So this is one way in which you can work together with nature rather than fight the system and create a whole lot of abnormal eggs. I talked about those embryos with all fragments on them. And what causes this fragmentation, we believe, is the energy source within the egg. So the mitochondria, which are the batteries, they are important. As you get older, your mitochondria are a little depleted. So what about taking mitochondria from one of the other eggs that you got and putting them into some of the other eggs? So you actually refuel them. So there's a nice publication that came out 3 years ago, but we've been doing mitochondrial transfer autologous. Just remember, autologous means from your own self. That means your own eggs fueling your own eggs, not borrowing mitochondria from somebody else as a donor, because that is not strictly ethically correct at this stage. Okay, and I won't go into the details. I'll just tell you that mitochondria have DNA, and you don't want to mix DNA of different patients together. So mitochondria autologous is great. They've shown a number of better outcomes, better fertilization, better embryo quality, better pregnancy rates. So we've been doing this for quite some time. Lifestyle modification goes without saying. Change your lifestyle. Eat better, antioxidants, etc. And obviously, now the thing about supplements, and I'm not going to say anything about supplements because I will create a lot of issues, but they talked about Q10 and DHEA. And there's merit to it, okay? But also look at all the other antioxidants that are on the market. There's lots of antioxidants. And the problem here, both in sperm and egg, is the buildup of oxidative stress. Oxidative stress is created by the environmental factors. So antioxidants work very, very well, and they should be promoted. So with the sperm, I talked about diet, recreational drugs, anabolic steroids. You need to take all that out, alcohol, cell phone, and radiation. What about men who are in testicular failure? What can we do about those guys? So we've done studies, and we've published it, on testicular stem cell therapy. So we've injected stem cells into men with testicular failure. We've managed to get sperm spontaneously. We've got pregnancies. We've published that paper. Supplements in men, as I talked about, it's pretty similar. Embryo quality, I said we must try and perhaps move towards use of AI to promote better embryo quality, selection rather. You can biopsy the embryos to see if they're normal or not. Expensive, but definitely of benefit. Okay, so better embryo selection using the new technology of not actually biopsying the embryo, but maybe even looking at the environment in which the embryo is growing and making decisions based on metabolomics and other factors might be the future as well. And finally, gamete donation. Implantation factors, what can you do about improving the environment in which the embryo finds itself? And there are a couple of important things. We talked about the window of implantation. There's a test called the ERA endometrial receptivity assay, which is actually of great value. It will determine for you when is the best time to put a frozen embryo back. Okay? The use of substances like GCSF and PRP infusion, we've published that paper on GCSF some years ago where we showed it does have a benefit in improving the lining, improving the implantation rates. We've now done a head-to-head study between PRP and GCSF, and we show that, in fact, they're much the same. So don't go to, they talked about the expensive things. You can actually get away with a cheaper form of treatment. So when the lining is not really perfect, you need to just inject some GCSF and improve that. Blood flow improvement, it's important to improve blood flow so that there's more nutrients going to the soil. Endometrial scratch, I think just fiddling with the endometrium, they say improves certain protein production and may help in implantation. The jury's out on that. I see a recent publication that has actually turned that on its head. And then, of course, surrogacy if all else fails. Now, I'm going to very, very quickly touch on this aspect. I want to just bring some important things to you. The consequences of failed IVFs. Okay, there's a lot of emotional issues, a lot of physical and physiological issues that come out. There's anger, there's this blame, there's all sorts of psychological aspects to a failure. Financial aspects, you spent a lot of money, you've just lost, you've got nothing to show for it. And then you start questioning God and spiritual things and things like that. So where does this problem start, actually? It actually starts with the doctors, I believe. I'm going to take a responsibility of some of this. So let me explain to you why. Because you have unrealistic expectations. And part of your unrealistic expectations as an IVF consumer is, first of all, created by word of mouth. So you got a friend who went to a clinic who got pregnant the first time. Wow, that's 100%. So you want to go to that clinic because you think it's going to happen to me. 100% expectation. When it doesn't work, you're dead. Okay, you're virtually now in doldrums. Then you get referred by a specialist. Your so trusted doctor, he's referring you to a fertility clinic. You've got so much faith in your doctor, you go straight to the clinic because you believe that's going to work. So again, your expectations are unrealistically high. And then the third one is your self-referral. So you start Googling and you start doing your internet searches and you say, wow, okay, these clinics or this clinic is for me, okay? But I want to just bring you to this very quick one. The HFEA, which is the Human Fertilization and Embryo Authority in the UK, did a survey in 2018 and they showed, in terms of priority, what patients go through in their minds before they make a choice of a clinic. One is geographical. So the one is they say, well, which is the clinic closest to me? I don't want to travel up and down. I don't want to go here and there. It's expensive. So they choose the clinic closest to them. But the very next point is the success rates. Success rates. So we're all looking at which clinic gives me the best success rate. And cost does come into it. I think in HFEA, it's state-sponsored, so they don't really look at cost too much in the UK. But in South Africa, for example, cost would be an important aspect. Now, where do you get this information from about success rates? It's either on the websites of the clinics, unaudited, okay? So individual clinics can claim whatever they want. Then they submit, some of the clinics are affiliated to a body, and they submit their data to this body, and the body may publish it on their website and say, this is our certain clinics that are affiliated to us, this is our pregnancy rates. For example, in America, there's a Society for Assisted Reproductive Technology, and they publish their so-called affiliated clinics' pregnancy rates, and that's where you get the information from. Clinics are not bound to submit their data, even in the United States. So there's no obligation on the part of a clinic to submit their data. And then these bodies, these affiliated bodies, may submit data to the national registry, or the national registry may then submit to the international registry. So all this is all about submitting data, okay? But the point I'm going to make is this data is retrospective, number one. And retrospective means, boom, I can change it if I want to, okay? This is an article that was published and looking at the German IVF registry. And this is a statement made in that particular article, which I think is extremely resonates what I'm saying. Prospective data is relevant and important. Retrospective data is open to abuse. Okay? So the argument that you should use prospective data is well-founded, but the argument to use retrospective data is not. And this is where the public is getting misled. They're getting swayed into, so what is the reality and what can you expect? ICMAT, International Committee for Monitoring Assisted Reproductive Technology, published this in 2021, last year. They looked at data from 2017. Reported on 2 million IVF cases, IVF cycles from 79 countries. 79 countries affiliated to ICMAT, and this is a database that is the biggest database in the world. And look at the pregnancy rate, 329,000 deliveries out of 2 million patients. What does it tell you? It tells you your pregnancy rate can't be brilliant. It can't be more than 25%. Look at this. This is their graph that shows the delivery rates in the gray columns for the North American continent, Latin America, Europe, etc., etc. So in a fresh cycle, you enter a cycle, it's a fresh cycle, what are your chances of falling pregnant? 25.3%. That's the highest pregnancy rate they're showing in the North America. Then you can say, take the frozen embryos from that fresh cycle and then use that in subsequent cycles. So this is called a cumulative pregnancy rate. And even at the best cumulative pregnancy rate, 48.2%. This is a huge database with 2 million cycles, okay? reported from all the continents, and look at on the last column globally, 18.7% on a fresh cycle, 26.3% on a frozen cycle, and 30.7% on a cumulative cycle. So some people say, why don't you put more than one embryo, increase my chances? Putting in 2 embryos or more still gives you a maximum of 37.8%, but the blue column is what you're looking at. That one says delivery rates per embryo transfer. And that's only 27.4%. Yet your multiple pregnancy rate goes up to 22.1%. So you've got bigger problems by putting in more embryos because you lose a lot of babies. You lose a lot of pregnancies. Because look at that, from 37% down to 27% because of the multiple pregnancy rate. So it's not always the answer, putting in more than one embryo and hoping that you're going to score. So what's my conclusion here, and I'd like to just summarize all these things. Beware of too good to be true marketing. Keep your eyes and just understand that if something is too good to be true, if a clinic is claiming massive pregnancy rates of 60 and 70%, ask yourself the question, really? So make a rational choice. It's difficult as a consumer out there because you really don't know the facts, and it's unfortunate, but you'd have to make a rational decision sometimes. Prepare yourself. Be realistic in what you can expect so that when you do fail, it's not it's understandable or more easy to accept. It's never easy to fail, but it's more easier to then accept the consequences of failure. Don't avoid the blame game. I'm almost certain that everybody would want to find a reason to blame somebody or something, but maybe there's a time when you should say that doctors do try their best. And the last point, and a very important point, is persist. Because cumulative pregnancy rates give you higher pregnancy rates. So if you fail with the fresh, go with the frozen. If you fail, maybe try again. But each time, it increases your chances of conception. So you should still stick to your guns and carry on with your treatment. That's what I have to say today. I'm sorry if I took a little bit more time than I should have. And thank you very much.
Help growing your family? The BioART Fertility Center in Johannesburg is waiting to help you fulfill your dream. Our highly professional staff offer you world-class care and cost so low that you can afford to dream. State-of-the-art equipment and remarkable success rates. We have been treating all aspects of infertility for more than 26 years. Contact us now to make your family a reality. BioART Fertility, where life begins.